Hello and welcome to the Project iCare podcast. This is a recording for healthcare providers who want to learn more about improving care for patients with substance use disorders and who might be at risk for HIV. I'm your host, Dr. Casey Claiborne, a clinical psychologist and research scientist at the University of Texas Dell Medical School.
And my name is Sydney. I will help narrate this podcast by defining terms, explaining concepts, and citing statistics that are relevant to the topic.
On today's episode, we will continue where we left off with Dr. Aliza Norwood. Previously, we discussed HIV prevention strategies, risk factors for contracting HIV infection, and PrEP, or post-exposure prophylaxis. Today, we will be discussing PrEP, or pre-exposure prophylaxis. We will address what PrEP is, who is eligible, and how to have a conversation with patients in addition to other valuable information. So while we're kind of on the topic of patient education, we've talked a little bit about PrEP, and I want to know more about PrEP. So PrEP, like you mentioned before, is pre-exposure prophylaxis. What exactly is PrEP, and how do you assess patients for whether or not they're eligible for PrEP?
Great question. So PrEP is a combination antiretroviral drug. It's a 2-drug combo, and before it was approved by the FDA to be used as prevention, it was already a component of many HIV treatment regimens. So it had been kind of tried and true, tested for being effective for HIV treatment in a 3-drug combo. Specifically, when we say PrEP, it's a general term, and we hope to, in the future, with more research, have other forms of PrEP. Mm-hmm. But when we say PrEP right now, because there's only one approved form in the United States, we're talking about Truvada. That is the brand name of a combo pill comprised of M-tricidamine and tenofovir. So it's a single pill. It's taken every single day. Right now, it's only approved for everyday use. There are trials ongoing, and in some other countries, even approved for more what we call on-demand PrEP use. So to be taken before or after sex with very specific guidelines on how many to take per week. But for the United States right now, with the data that we have, really the only recommendation we make to patients is to take it every single day for prevention of HIV. And what it does is it prevents HIV infection on a cellular level. And we have great studies in both men and women and transgender populations that there is anywhere from a 90 to 99% risk reduction when taken every day. So it's highly effective as HIV prevention.
That's great. So, I can imagine as a provider, it's really difficult to talk about sexual health and to assess eligibility. So how do you have that conversation? How do you approach potentially talking about PrEP eligibility with a patient?
I think a lot of providers have some uncertainty about how to approach conversations about sex. I would encourage everybody to become more familiar and make it just kind of a standard part of every intake for a patient. So just like we have universal precautions and we have questions that we ask of everybody, taking a good sexual health history should be a part of, just primary care in general. So what I do to kind of standardize is that I tell patients, I ask these questions of everybody. And a common framework that the CDC endorses is called the 5 Ps. The 5 Ps stand for partners, practices, protection from STDs, prior STDs, and prevention of pregnancy. So for example, for partners, you can start with an opening question like, are you having sex? Or in the last 6 months, how many sex partners have you had? If they've had recent sex partners, you want to ask if those partners are men, women, or both. And then you can tailor the rest of the conversation kind of based on your relationship with your patient and based on the patient's responses. So it's going to be kind of, again, tailored to the individual. For example, if a person is in a mutually monogamous relationship with an HIV negative partner and neither person uses IV drugs, you can be pretty reassured that the person's not going to contract HIV. You may not have to ask as many detailed questions about sexual practices, but you can still ask about pregnancy prevention if either partner is able to get pregnant. However, if your patient is having sex with multiple partners and is unsure about a partner's HIV status, you'd want to ask more about sexual practices because you want to get a better sense of what their potential risk factors for getting HIV are. For practices, the second P, you want to get really specific. You can say something like, in order to know if you need specific testing, can you tell me what types of sex you have? So basically you're asking what body parts they're using during sex. So you can say, are you having oral sex? Are you having anal sex, vaginal sex? And it's important that you present these questions in kind of an open, non-judgmental way. You should also know common non-medical terms that people may use. And some patients may prefer you use medical terms versus more informal terms. That's kind of just person dependent. So for men who have sex with men, receptive anal sex, so the person receiving anal sex, is called bottoming, and insertive anal sex is called topping. Phrases like that are good to know and maybe better for if the patient wants to have a more informal conversation, then you can use those terms. It's important to know basically for the practices part who's putting what where, so you know what testing needs to be done, and that's partly because different sex practices have different likelihoods of transmitting HIV, as we talked about in part 1, and partly because you're going to want to do STD testing for gonorrhea and chlamydia for every part of the body that's been used during sex. So you're going to want to do pharyngeal swabs for oral sex, urine tests for vaginal or penile sex, and rectal swabs for receptive anal sex. Another part of practices is asking about drugs or alcohol used during or before sex, because those can lower inhibitions and they have an association with a higher incidence of HIV transmission. So moving on for protection, the third P, you want to ask open-ended questions about what your patient uses for protection. If they use condoms, ask if they use lubrication. If they use condoms only intermittently, you can ask about how often they think they use them. And you can do some motivational interviewing around, why they're not using condoms more if they're at risk for STDs. It's important to reiterate that condoms are really the only protection we have against non-HIV STDs. Prior history of STDs, that's pretty straightforward. Prevention of pregnancy is going to be tailored to the gender of your patient and whether or not they would want a pregnancy, either to be a parent or have a child if they can get pregnant. And if not, you can ask about what they're doing to prevent pregnancy if they're having sex that could lead to pregnancy. And that could steer you into offering contraceptive counseling if appropriate. And then you can end this conversation with something like, what other questions do you have? So explicitly inviting the patient to ask questions that they may have about sex, because it is something that people tend to have questions about but may feel embarrassed asking in most situations. So in terms of assessing eligibility, in order to be eligible for PrEP, a patient must be HIV negative. So they must have a documented HIV test in the previous 7 days. Okay. So within a week of prescribing. We recommend 4th generation HIV antibody and antigen tests. There's a lot of 3rd generation tests can be used for initial screening and then followed up with a confirmatory test. That's necessary. And then in terms of eligibility, in terms of practices, a patient who is either in a sexual relationship with an HIV positive partner or not in a mutually monogamous relationship with somebody who is known to be HIV negative. So meaning there's some uncertainty around a sexual partner's HIV status, and if that partner is engaging in activities which might increase their risk for HIV. So for example, if they have multiple sexual partners also of unknown HIV status, if they are using IV drugs, or if they are exchanging sex for goods or services. There are specific demographics where we know that the incidence is higher. Somebody who might be a candidate would be, for example, a gay or bisexual man having sex without condoms. Another flag would be if somebody has multiple STDs, like a 6-month period, man or woman. That usually raises my concern that they're, having sex without condoms. And I would definitely approach that person just about a conversation about sexual practices to see if they might be a candidate for PrEP. And then people who have injected drugs in the past 6 months and are sharing needles. All of those people would be candidates for PrEP. And then we check to make sure there's no contraindications to be on the medicine. So Truvada is not approved for people who have certain cutoff of kidney injury. So if their creatinine clearance is less than 60, we would not start Truvada. And then this is kind of a relative contraindication, but ability to take the med daily and ability to follow up in clinic, because it is recommended to get every 3 months to check in the clinic to see if risk has changed, to get counseling, to get labs done, and to check in about adherence. So if you have a determination that somebody really can't take it daily, then that could theoretically set them up for a risk of resistant disease, or they could be taking a medicine, not follow up in clinic, not get labs, and you don't want to miss, a potential side effect. So that's something we also take into consideration.
Okay, so who can prescribe PrEP? Do you have to have a specialization to be able to prescribe, or?
So you don't. You should have training, and we are going to do a standardized training at CommUnityCare where we've created a community care specific guide, and we'll do directed training for providers and cultural competency training for staff. If anybody listening to this has an interest in that, please reach out to me and we can make sure to incorporate them in the training. And so I would say, who can prescribe PrEP? Really, any provider with adequate training. And that can be, training from somebody who has prescribed PrEP in the past, use of guidelines. It can really be, guideline driven. There's a lot of different guidelines out there. San Francisco City Clinic has great guidelines. New York State has guidelines, CDC. So there's a lot of resources out there.
Great.
So I think that primary care doctors, as really the front line of patient care, who are doing more of these sexual histories and have, a more ongoing relationship with patients, they really should be the front line of PrEP prescribing. Okay. So I think any doctor who's doing primary care, whether that be nurses, APPs, physicians, family internal medicine doctors. I also think that OB/GYN doctors really should feel empowered to get trained to do PrEP prescribing. We mentioned some healthcare disparities earlier on in the podcast, and I do want to point out that in Austin, heterosexual African American women have a 14 times greater HIV incidence than white heterosexual women. Again, HIV can affect anybody, and there are large numbers of heterosexual women, again with these health disparities, who I think are being missed because younger women are generally going to their OB/GYNs more than their primary care doctors. So I think, training up OB/GYN doctors and, really remembering that if you see an STD, you should think about asking the person about potential risk factors that might make them a candidate for PrEP could really help prevent HIV infection.
Okay, absolutely. So what's kind of the process for providers to initiate PrEP prescriptions for their patients?
So the process would be first that eligibility. So talking to a patient about sexual practices, IV drug use, anything else that would increase their risk of getting HIV, and then a series of lab tests. So generally, the most important lab test is getting that HIV test to make sure that they're HIV negative. We also recommend screening for any symptoms of acute HIV. And so there's a window period, depending on the test that you get, of about 14 to 21 days. Okay. And so making sure that there hasn't been any recent acute HIV symptoms, which are usually described as a mono-like illness. So having kind of flu-like symptoms, feeling very fatigued. There's usually a maculopapular rash, fever. Those symptoms in the context of someone who had a recent possible HIV exposure should prompt you to get an HIV RNA test, which tests for the actual HIV virus rather than an antibody to the virus. And that test has the shortest window period and is most accurate. So it's best for someone who you have a high suspicion of an acute HIV infection.
Certain tests should be completed in conjunction with HIV testing to determine PrEP eligibility. Dr. Norwood will discuss some of these tests. These tests include the CBC, or completed blood count, and the BMP, or basic metabolic panel.
The next step is getting just basic CBC. We do hepatitis screening for hepatitis B and C and test of renal function. So usually a CBC, BMP, and hepatitis screening. We'll usually also test for men who have sex with men. We'll do syphilis screening as well with an RPR. And then we do test for STDs in general with every body part used. So this is why it's so important to get a good sexual history. If your patient is having oral sex, anal sex, penile or vaginal sex, you want to test all of those different areas for gonorrhea and chlamydia instead of just one or two site testing. So all of that goes into our initial evaluation. And then to prescribe PrEP, depending on your access to your clinic, we generally prescribe 1 to 3 months of PrEP, of the pills. If you have the luxury of having openings in your clinic to see the patient back in 1 month, that's really ideal to check in about adherence, to check in about any side effects that the patient might be having. Every 3 months is really the agreed upon consensus for how often check-ins should happen, including repeat lab testing, STD testing, and checking in about adherence.
Okay, that's helpful. Well, let's talk a little bit about funding. So I know PrEP is expensive. So is it covered by insurance?
So PrEP is covered by the vast majority of commercial insurances.
Okay.
So most people can get PrEP through their insurance. However, copays can vary widely. And sometimes the copays can be really, really expensive. So Gilead is the pharmaceutical company that makes Truvada. And so Gilead does have a copay coupon card that patients can apply to. And depending on their income and insurance, Gilead can cover up to $7,200 in copays per year with no monthly limit.
Okay.
So it's a really good, it's the Gilead Advancing Access program, and we can supply a link to that. Here in Austin, for our patients at CommUnityCare, many of them have MAP or CCHC insurance. So if they are in that boat, then we can refer to our patient assistance program.
Okay.
The patient assistance program can interface with Gilead, do the necessary paperwork with the patient, and they have the potential of getting the medication covered completely. So no out-of-pocket charge. So we do have options for those uninsured patients. And then Medicare and Medicaid also do cover, but again, depending on what types of coverage they have within Medicaid and Medicare, may also be eligible for assistance either through the copay card or third-party coupons.
Oh, great. That's really helpful. So we've talked a lot about HIV prevention. I talked about the past. We talked about where we are today. I kind of want to cover a little bit about where we're headed. Do you think, we'll ever have an HIV vaccine? What does prevention look like in the future?
So I do. I am really excited about this field of research, and I actually worked at Bridge HIV before I moved here to Austin in San Francisco. And that's a part of the San Francisco Department of Public Health where we did HIV vaccine studies and HIV prevention studies.
Okay.
So in terms of HIV prevention, there have been over 140 HIV vaccine trials to date. So it's something we've been working on for a very, very long time, for over 40 years. Wow. And HIV is a really, really tricky virus. So part of the reason that we don't have a vaccine yet is because it's very, very difficult to create an antibody response in a human that effectively is able to neutralize HIV. Because when we talk about HIV, it's really not just one virus. It's many, many species and subspecies of viruses that have mutated over the years. There's actually different clades depending on what region of the world you're in. And so it looks different in different parts of the world. And what we would want with an HIV vaccine is really something that can be given to anybody and prevent HIV in all of its forms.
Absolutely.
So because HIV mutates so rapidly, it's been really difficult to develop something that's able to attack any form of HIV, like I said.
Okay.
There have been some minor successes. There was a trial, sometimes colloquially referred to as the TIE trial or the RV144 trial, which showed about a 30% efficacy.
The Thai HIV vaccine efficacy trial was a landmark case conducted by the U.S. military's HIV research program. Study results were reported in 2009. This vaccine trial combined two vaccines based on strains of HIV that commonly circulate in Thailand. The trial results showed that this vaccine regimen safely lowered the rate of HIV infection by 31.2% compared to a placebo. This study demonstrates the potential for an HIV vaccine in the future and provides scientific basis for current vaccine development and testing. Now let's listen as Dr. Norwood discusses some fascinating ongoing vaccine studies.
There's a couple of current vaccine studies that are ongoing right now that are going to be really interesting and shaping the future of where we're going with HIV vaccine research. One is called the AMP study, and AMP stands for Antibody-Mediated Prevention.
Okay.
It's an international study. It's fully enrolled. It's still ongoing, so we won't have results for a while. But it's looking at the administration of broadly neutralizing antibodies, which were actually first discovered in patients who were infected with HIV but stayed healthy for a very long time. They're called long-term non-progressors. And we actually took samples of blood from these people who were able to live much longer without complications from HIV than others and study their antibodies. And what was unique about their antibodies is that they were very complex and they had evolved along with HIV to be able to neutralize parts of HIV that are conserved even when they mutate. So what we are trying to do with this study is make synthetic antibodies that look like that, infuse them into people who are HIV negative but might be at risk of contracting HIV, and see if that helps over time to prevent HIV along with everything else that we would be giving them for HIV prevention.
Okay.
So if that study showed some effectiveness of these broadly neutralizing antibodies, they would be the targets of further vaccine studies that would try to direct a vaccine to create an antibody like that.
Wow.
So that's just one example of something that's ongoing. There are also studies about looking at tests of cure. So not vaccines per se, but studies that are enrolling people living with HIV and seeing if there are different treatments or injections that we can give that stimulate the native immune system to better kill HIV.
Okay.
So there's one called the PenVax enrolling in LA and San Francisco that's looking at that. So in terms of non-HIV prevention studies, there's a lot of work going on in the field of microbicide development, so using lubricants or other microbicides that can be used for HIV prevention, and looking at using tools that have been traditionally used for birth control, like Nuva rings and things like that, and vaginal rings that have anti-HIV medications within them, hopefully to be combined with contraceptives in the future. So a lot of interesting developments.
Exciting. Yeah. Well, I'm very excited to kind of see where we are a few years from now. I think it'll be really interesting. Aliza, do you have anything else that you'd like to add?
The last thing I would say is that, I think the onus for really preventing HIV infections and getting to our ultimate goal, which is no new infections and no more HIV, we cannot do that without primary care providers, nurse practitioners, advanced practice practitioners, and really everybody who hasn't traditionally been a part of prescribing these medications and talking about sexual health, getting them in the mix and really doing community outreach. So I'm really excited for this future and for collaborating with people who are interested.
Very cool. Well, we will link everything that you've mentioned in the podcast to our website, and then also allow people to contact you if they're interested. This has been a Project iCare podcast with special guest Dr. Aliza Norwood. To learn more about Dr. Norwood and her work, check out our website, where this information will be linked under today's podcast description. If you like this podcast and would like to learn more, check out our website, linked in the description below, or find us on Facebook at UT Health Innovation Lab. Thanks for listening.